Okay, let's try that again. All right, we're good. Hey, thanks, Dewey. And also a special thanks to Stand With Trans organization. You guys are awesome. It's really great to be invited. I'm a pediatric endocrinologist at the University of Michigan. I see some familiar faces already on the participant list. Hi, guys. I have a great job. Pediatric endocrinologists get to see kids with endocrine problems, whether that's problems with growth, problems with puberty. But the area of pediatric endocrinology that I spend an awfully lot of my time is working with young people and their families around topics of gender and gender identity. And I think that's so fun because every day I meet amazing, brave, and really resilient, inspiring kids. And I get to meet really brave, resilient, and really inspiring parents too. What my goals are for today's talk is to just go through some of the basics and updates on hormonal care for trans and non-binary youth. But also, you know, I know that a lot of people are going to these talks and watching them recorded later, but you guys get this special privilege of being here live. So I do want to leave some time for questions or discussion at the end so that we can sort of make sure that everyone's important topics that they came to learn about are covered. So just a little bit about where I work. So Ann Arbor, Michigan is the home of the University of Michigan, and our children's hospital is called Mott Children's Hospital. Our pediatric gender clinic opened about 6 years ago and averaged seeing about 100 new patients per year. People are referred at all different ages, but I would say that there's a cluster in that pre-pubertal or going into puberty age group, 7 to 9 year olds, and then there's a cluster in the high school age group, and we're seeing an awful lot of kids in that high school age group more recently, maybe even 3/4 of the kids in that 14 to 17 year old age group, 1/4 in the younger group. In terms of the sex assigned at birth for the patients that we're seeing, about a 1-to-1 ratio for the younger kids. So assigned male or female at birth, about equal numbers. For the older kids, seeing about 2-to-1 assigned female at birth or male identified or transmasculine patients in that older age group. And from what my colleagues across the country are telling me, that sort of dichotomy is sort of similar at other children's hospitals where the high school age group, we're seeing overrepresentation these days of more transmasculine or assigned female at birth patients. So typically what happens is either a pediatrician or a therapist will refer a patient to clinic. The patient will and their family will have a psychosocial and gender assessment with one of the social workers, and then they'll see one of our doctors. And at the mental health assessment, you know, I think one of the things that I really want to make clear is that we're not trying to do these mental health assessments as a way to make things harder for families to access care. But we're seeing patients and families at all different stages and phases of gender identity and gender acceptance from patients and families. And so at the meeting with the social work, at the start of the meeting, there's setting some goals from the patient's perspective, from the parent's perspective, getting a history from the patient, and getting the story from the parents as well, focusing on the child's mood history and mood symptoms, especially how it relates to puberty, talking about where the child lives, do they go to school, who else is in their house, who else is in their family, any psychiatric history, medical history, their development, doing some mental status evaluation, so standardized tests, and then the social worker would then share an impression and plan with the patient and family. And then oftentimes the next step for the family would be to see one of the doctors. And in our clinic, we currently have 2 social workers that are doing these assessments, and we have 5 doctors that are seeing patients for that visit afterwards. So I wanted to take a step back for a second and talk about what I would define as gender identity. To me, gender identity is how I know myself inside as a boy or man, as a girl or woman, perhaps a non-binary person, or maybe I have another word that I use to describe my gender identity, or maybe I don't identify as having a gender identity. But of course, gender identity is interesting because it's not something that I can measure with a blood test. It's not something that I can measure with an x-ray. And it's something that comes from the child themselves as you ask them to explain how they're identifying inside. And having a difference in gender identity itself from the sex assigned at birth is not considered a medical problem or a mental health problem when you talk to doctors and mental health professionals. We all have a gender identity. Sometimes it matches our sex assigned at birth, sometimes it doesn't. But simply the fact that there's a difference in that is not a health problem at all. There is a term called gender dysphoria, and controversial or not, it is in the DSM-5, which is the manual for psychiatric disorders. Gender dysphoria, to me, is just a way to say not only do I have a difference in gender identity, but it also is causing me to feel not good in some way, whether it's anxious or depressed or just uncomfortable in my own skin. And so gender dysphoria is a way to say, yeah, I know that you said that it's not a problem to have a difference in gender identity, but it's a problem for me. And it's causing me to feel not so good. And so if someone has gender dysphoria, then you say, okay, that's a medical problem. Well, what are the options to treat that medical problem? And sometimes in clinic, I like to compare gender dysphoria to other medical problems to put it into some context. So, for example, anxiety is a medical problem. We would all agree with that. And there are so many different ways that people could treat their anxiety. There's a bunch of non-medical ways that people treat their anxiety. For example, seeing a therapist, or counting to 10, taking deep breaths, doing yoga, doing meditation, avoiding things that make you anxious. And then there's medical ways that people treat anxiety, like using anti-anxiety medications prescribed by a doctor. And someone with anxiety would talk to their parents, talk to their therapists, talk to their doctor, talk to their whole team, all the people that love and support them, and figure out what is the best way for my anxiety to get better. And it might be a combination of non-medical and medical treatments. When I think about a child with gender dysphoria, I think about it in a very similar way. There's lots and lots of ways that people treat gender dysphoria in non-medical ways. Getting a haircut, not getting a haircut, using a name or pronouns that feel more comfortable for them, wearing clothes that they pick out that feel more comfortable for them, coming out to their parents, to their loved ones, to their teachers, to their friends, wearing a binder, all of these non-medical interventions, I think we oftentimes lump together as social transition. And so, when someone says, you know what, Mom, you know what, Dad, I think I want a short haircut because that aligns better with my gender identity. They might not be thinking, you know what, I'm treating my gender dysphoria right now with this haircut. But to me, that is what they're actually doing. It's a treatment to reduce the stress related to this disconnect between gender and body. And for some people, that those non-medical treatments for gender dysphoria might be a perfect treatment for their gender dysphoria, and hormonal medication wouldn't necessarily be helpful or necessary. But for a lot of kids, especially the kids that end up seeing me, perhaps the gender dysphoria is to a point where it is causing more distress despite some social transition, and hormonal considerations are then discussed. One thing that I'm always mindful of is that parents and guardians present to our clinic at all different levels of support. Even more important than anything that I put on the last slide in terms of treatment options for gender dysphoria, I would say acceptance from family is number one. We think that family acceptance is the critical mediating variable for not only trans, but the whole LGBTQ rainbow, adolescent and young adults, mental, emotional, and physical well-being. I really like the resources at the Family Acceptance Project if families are struggling, maybe struggling themselves with acceptance, or maybe trying to support a family member who's struggling. That we know that rejecting family members can become less rejecting over time. And usually access to accurate information can be the critical factor in moving from more rejecting to less rejecting and accepting. So as an endocrinologist, I love talking about hormones. And so I wanted to shift gears a little bit. And this is just a picture of testosterone production across the lifespan. And we could have a similar looking picture with estrogen, just kind of reversed. But in fetal life, you can see there's a big difference starting at about 8 weeks of gestation between testosterone levels in male and female fetuses. And that big difference in testosterone level is responsible for what we call the primary sex characteristics, the anatomy, having a penis, having a vagina, having a uterus, having testicles. Those sex hormone differences in fetal life are responsible for the different body parts of people assigned male and female at birth. Then we're born, and then you can see another little surge of hormones right after birth. That's called the mini puberty of infancy. Not really sure why we have a little surge of hormones after birth, but might have something to do with attachment to your new parents. That little surge of hormone might help you fall in love with your mom and dad, or your mom and mom, or your dad and dad, or your parents. And then there's a period of quiescence. So the gonads shut down and aren't making hormones at all, and that's called childhood. And in childhood, whether you're assigned male or female at birth, your body looks very similar, and just your private parts, or your primary sex characteristics, are what makes you different from the opposite sex. And then all of a sudden, of course, there's a big surge, and that's called puberty. And puberty causes the changes that we refer to as secondary sex characteristics. So for people assigned male at birth, that means a deeper voice. That means more body hair, more facial hair, more muscular frame, a more dramatic growth spurt. Adam's apple. For people assigned female at birth, that means breast development, softer, more glowy, feminine skin, more feminine curviness, growth spurt that's less robust than the testosterone fueled growth spurt. And those secondary sex characteristics contribute to how we can look at someone and make an assumption about whether they were assigned male or female at birth. So someone who has a gender identity that's not matching the sex assigned at birth may struggle with the development of secondary sex characteristics because it may call them out as a sex different from the gender identity that they're affirming. So just to put what I just described into picture form, these are all kids that haven't started puberty. And if I told you that all of these kids are affirming a gender that is different than the sex they were assigned at birth, and expressing that, then I think the point made is that you can't tell because none of them have developed any secondary sex characteristics. And these are kids that are all expressing a difference in gender identity that live in Amsterdam. And Amsterdam actually was the very first pediatric gender clinic in the world back in the 1990s. And in this clinic, they were thinking about that question of, gosh, kids that are coming to see us as puberty is starting, going through puberty doesn't seem like a very good idea for their mental health and also for their long-term ability to present themselves in the way that they may want to present themselves. And so they said, gosh, we should just start treating with hormones at the beginning of puberty. But then they said, puberty starts when you're pretty darn young, oftentimes when you're 10, 11 years old. That might not be the best time to be making permanent decisions about how our body works, how our body looks. And so they said, we have this sort of ethical and medical dilemma. Medically, we'd want to start hormones young. Ethically, we want to wait. So how do we sort of how do we get around this sort of conflict? So they said, well, what if we use medications to pause puberty at the very first onset, noticeable puberty, and then it allows the child time to get a little older and wiser and more worldly and have more certainty about which puberty seems right for them. And then later on, we could then think about testosterone and estrogen at age 16. And they said 16 based on the fact that that was the age of consent in the Netherlands at the time. And then they said, and then they could decide on surgery by age 18. So that was all well and good, but that was the 90s, and there's a lot of differences in the patients that we're seeing today compared to then. One big difference is when you read the articles from the Netherlands, they're really talking about kids that were coming to them as younger kids, and then sort of they were monitoring them for the onset of puberty and then starting pubertal suppression. But as I pointed out, more than half of our patients are coming after puberty has started, oftentimes well after puberty has started. Another big difference is a large increase in the number of kids that are coming to gender clinics. You know, in the 1980s, there was a study that said 1 out of every 30,000 people identified as transgender. And in 1995, I believe, adults in the US reported that 1 out of every 200 reported a gender identity that was in some way different from the sex that they were assigned at birth. So that's several orders of magnitude different in terms of prevalence. So we're seeing a much higher percentage of kids and coming in with all different stories of their gender identity understanding. I think a third big thing, and something that even seems more relevant over the last several years, is the emergence of non-binary identity and how that relates to the work that the Dutch were doing 30 years ago. You know, sometimes it's tricky for endocrinologists because we have 2 hormones, estrogen and testosterone, and those are binary. So how do we maybe apply lessons from what we know about endocrinology to try to help in different ways non-binary folks? There's also concern about this idea of waiting till 16 to start hormones, especially for kids that are very, firmly committed to a gender identity, that waiting until 16 without any puberty isn't necessarily super healthy for your bone density, and also can be super hard for a young person to not only be different because they have a difference in their gender identity, but also be different because they're the only kid that hasn't started puberty. And that could be a kind of a double whammy. So, oftentimes we are waiting till 16, but in a lot of other kids that makes more sense to start younger. We're really making more individualized decisions instead of having a hard and fast age cutoff. And then I think another big difference, of course, is that because of sessions like this, because of the internet, parents and patients are coming in really knowledgeable, and oftentimes, coming in with pretty concrete ideas about what their goals are for our visit. And so sometimes I have to take a step back and make sure that that I'm doing my due diligence, but at the same time, I often reflect on the fact that out of anyone in a room, the patient knows themselves the best. The parent knows themselves second best, and I come in a very distant third. So if I'm sort of outlining what we know and what we don't know about these medical interventions, working with my social worker, working with parents, then all we can do is our best job to make these challenging decisions with young people and their families, with a goal of helping these amazing young people live their happiest, healthiest, most productive life. So in terms of medical interventions, now I like to break it down in terms of like 2 buckets of medicines. One are medicines that stop or suppress your body from making hormones, and the other bucket is medicines that give your body hormones that it's not making. So in that first bucket, and oftentimes we refer to this bucket as blockers, we have GnRH analogs, we have progestins, and we have spironolactone. So GnRH analog is classically what people think of when you use the word blockers. They're the medicines that have been used for decades in kids with puberty that starts too young, so for precocious puberty. And how GnRH analogs work is they turn off the signal in the brain that's telling the ovaries to make testosterone or estrogen, or the testes making testosterone. So no signal comes from the brain, and then when you take away the GnRH analog, those signals pick up again. So the point of using a GnRH analog would be someone that's early in puberty, would allow them to not progress through puberty, and also it would be quote unquote reversible, meaning that puberty would pick up where it left off. I think, as we've all been sort of inundated with this political discourse over the last several years, the blockers or pubertal suppression has been a big target of people trying to pass laws and make trans care less accessible. So what are the concerns that people might have besides just being anti-trans? I think one concern is if you're suppressing a normal puberty, then during that time, your bones aren't getting as strong as they would if you were going through puberty. But if we're using blockers for a limited period of time, then we see bone density catching up. We have concern about a child being the last one on the block to start puberty, but being the last one on the block to start puberty might be better than going through the wrong puberty and feeling depressed and anxious about those changes. I think some of the things that I think are more valid or more interesting to think about is, if you don't go through your own body's natal or natural puberty, then you don't get to know your body in a pubertal way. So for example, someone born with a penis doesn't go through puberty. They might not have an intimate relationship with their penis to understand how it works as a sex organ, as much as boys that go through puberty. Similarly with trans guys that have a vagina and clitoris, they might not be as intimately aware of how their body works because they didn't go through those puberty changes and experience some of those changes in libido and in sexual function. And then we're also, if someone's on a blocker, that we do say that it's reversible, but if you never go through puberty because you go from blocker to hormones, then you're not having an opportunity for your body to make sperms or eggs that you could then think about preserving. So the blockers itself aren't causing infertility, but kind of going down a pathway of not having an option for egg or sperm preservation. So what are some other medicines that I put in the blocker category? Progestins, whether it's a pill called norethindrone or shots like Depo-Provera or an IUD or an implant. Progestins are hormones that are made in males and females, but are made as part of the menstrual cycle. The times that I use progestins the most are, let's say there's a 15-year-old assigned female at birth, identifies as a trans boy. Not sure if testosterone is right for them yet, but really doesn't want to have periods anymore. We can use progesterone only birth control to help stop having periods without committing to testosterone. Progestins are also being more and more popular in trans women. Progesterone is a hormone made by cis women, and there's some thought that it helps with breast development filling out and maybe some effect in female libido. Anecdotal studies are telling us that trans women may benefit from being on progesterone, but it hasn't really emerged as the standard of care because there hasn't been larger studies about it. And then spironolactone and bicalutamide are specifically used for trans women. They block testosterone action. Spironolactone has been around for a long time. It works pretty well. Bicalutamide may work a little bit better, but it does have some concern in adults for elevating liver function tests. So I usually use spironolactone over bicalutamide unless we're having a lot of trouble with blocking someone's testosterone. And then the second bucket, right? Testosterone and estrogen. testosterone and estrogen are used to try to bring someone's hormone level up to what's normal for a boy or girl their age if their desire is to go through a binary transition. And we're going to spend some extra time today on non-binary transition. But historically, we'd use testosterone and say, okay, a 14, 15, 16-year-old boy has a testosterone level in this range. If we mimic that with giving testosterone, we would expect the same things to happen to promote male puberty in that boy. And similarly for trans girls using estrogen. Testosterone comes as an injection. That's usually the best way to give testosterone, but also can be given as patches or gel. Estrogen is usually given as pills, but can also be given as patches or injections. And then we're following blood tests to make sure that hormone levels are around what we would expect for a boy or girl of their age, and expecting, if we're doing that correctly, to mimic normal puberty. And then the risks of testosterone or estrogen are really the risks of having a normal testosterone or estrogen level for a boy or girl their age. So, you know, some of the biggest complaints I get with kids on testosterone would be acne, maybe a hairline change. On estrogen, we encourage people to definitely not smoke, because estrogen plus smoking, whether you're assigned male or female at birth, can lead to a higher risk for blood clots. Anyone with breasts, whether they were born with them or they developed them, not born with them, but made them because they made hormones themselves or because they were on estrogen, would need the same mammogram screening, usually starting at age 40 as any other person with breasts. And anytime that anyone anywhere on the gender spectrum has a body part that requires cancer screening, currently the recommendation is to do that screening at the same age that you would have it, regardless of your gender identity. So that includes pap smears at 21, mammograms at 40, colon cancer screening, prostate cancer screening at the age where other people with those organs would have them. And then, you know, surgeries are sometimes discussed in pediatric clinic. Having chest surgery, especially mastectomy, is more common under 18 than any other gender surgery, I would say, just because surgeons are willing to do it under 18 oftentimes, and having breasts can be really debilitating for someone with a lot of breast dysphoria. Genital surgery, such as phalloplasty or vaginoplasty, oftentimes delayed until 18. But I think one thing that I want to just point out here is, just like I said, that not everyone with a difference in gender identity needs any medical intervention. Not everyone with a difference in gender identity needs any surgery. This is just showing that, gosh, in the lower right, 72% of trans men, or people identifying as trans men, don't want to have a phalloplasty surgery. You know, and but 26% really do, and that's something that's really important to them. So whether someone is or isn't interested, has or hasn't had, can or cannot afford a certain type of surgery, doesn't validate them any more or less in the gender identity that they are affirming. And I think I wanted to just explore a little bit non-binary identities as its own sort of entity, because something that I've been thinking about a lot more as more and more patients have come to me thinking about their gender in a more nuanced way than maybe my generation had when I was growing up. And so, for example, there could be a 16-year-old who has been on blockers since they were 12, and they are saying, you know, male puberty, that doesn't sound great to me. Female puberty, that doesn't sound great to me. I like no puberty. And I think that that's a reasonable desire, but is it safe from a medical perspective? Probably not forever, right? Probably we need some sex hormones in our body. And so really trying to figure out, okay, what are the aspects of female or male puberty that are appealing to you, if any? What are the aspects that are most distressing to you, and let's figure out how to get you through a puberty that may not be your first choice. Your first choice might be no puberty, but let's figure out what would be the safest way to help your body go through a puberty that is reasonable for you. How about a 15-year-old that's assigned female at birth that's saying, you know, I identify as non-binary or maybe transmasculine, but I know that I don't want to be on testosterone for the rest of my life. I don't have any desire for like a beard, but if my voice was a bit lower, I feel like that would make me a lot more comfortable and confident. You know, if you go look for studies about using blockers, using hormones, and look for like long-term outcomes data, mental health data, you'll find some pretty awesome data to say that those medicines help. But if you're going to look for an exact situation like this, does it help to give someone a little bit of testosterone to make their voice a little bit deeper? There's no long-term studies on that. That puts doctors sometimes in a tricky situation. We know that testosterone could do that, you know, using a smaller dose of testosterone for 6 months, for example, would lower someone's voice a little bit. And so I think in the most recent recommendations come out from the World Professional Association for Trans Health, WPATH, they have said that, you know, not every person should be following sort of a binary protocol for hormones. If it makes sense from a medical safety perspective, then finding out what a patient's goals are and trying to you know, think critically with that patient about how that might be accomplished could be something to consider. So these are tricky ones, but you know, I do have some patients that have started testosterone with the idea that they might not want to continue it forever, or some patients that started testosterone with the idea that they did want to continue it forever, but then came back and said, you know what, Dr. Schumer, through the process of being on testosterone, I've recognized that my identity is more non-binary than I initially thought. And I'm pretty happy right here where I'm at, and I'd like to stop the testosterone. So I say, great, wonderful. I'm glad that you figured that out. Let's stop the testosterone. I think that the tricky thing sometimes is people might ask me, hey, Dr. Schumer, how many people stopped taking testosterone once started? And I think implied in that question, or even the same question for estrogen, right? I think implied in that question is how many people stopped and resented you for giving it to them in the first place, right? How many people think that they made a big mistake? That number is very low. But the number of people that are even planning on stopping and then starting hormones is growing as people are identifying more along a non-binary spectrum. And I think that that's okay. But just making sure that as we're talking about how medicines work, we understand what's more permanent, what's less permanent, and how could these medicines help or not help them, and deciding if it might be a good choice for them. What are some other common discussions that come up a lot in gender clinic? We talk about breast binding quite a bit. You know, breast binding can be safe. I encourage people to wear a binder that fits. I really like a website, GC2B, which has a really good sizing guide, and binders should be worn, you know, in situations where they're helpful. But when you get home, trying to minimize use, so trying not to wear more than 8 hours per day. We are, you know, connected to the adolescent medicine clinic, and we are seeing some of each other's patients from the eating disorder clinic and the gender clinic. I think sometimes patients with difference in gender identity may have an unhealthy relationship with food, whether overeating and binge eating, or having caloric restriction issues as a way to change their body in a way that feels more comfortable. And really the goal is to emphasize that that's not a healthy way to change the body. And working with our colleagues from eating disorder clinics in co-management sometimes is helpful. You know, working through family conflict, working through school conflict, talking about sexually transmitted infections. You know, who if anyone are you intimate with? What body parts does that person have? What body parts do you have? Are those body parts touching each other? You know, really getting more into the nitty gritty instead of are you attracted to men, women, or both, which is what I learned in med school. That doesn't really cut it when we're talking about young people with diverse gender identities and their significant others. But talking about how to stay safe, that none of these medications are contraceptives, so that avoiding pregnancy even when you're on hormones is important if pregnancy is not desired. And then if it is desired, then talking about that and talking about how to connect them with experts in fertility if they're having trouble with fertility. Talking about substance use, talking about their hormones and issues with any side effects from their hormones, and then always reevaluating the care of plan. So, when I have someone on, let's say, estrogen, and it's our first, visit back, I'm going to tell them, the first question I'm always going to ask you is, let's check in on your name, your pronouns, and how you identify today. The second question I'm always going to ask you is, are you feeling like the decision to be on estrogen is still the right decision for you? And the answer could be yes. The answer could be no. And I don't care which one it is, but I want to open-endedly ask you that and reevaluate our plan each time to make sure that what we're doing seems like the right plan moving forward. So I think pictures speak louder than words sometimes. Here's more from the book, this cute, really cool pictorial book from the Netherlands of kids that are expressing a gender identity that is different from their sex assigned at birth before puberty has started, and then other kids that have been seen in the Amsterdam Gender Clinic that are able to live their authentic life and go out on their adulthood better able to express their gender identity, whether that's male, female, or non-binary, in a way that feels more comfortable to them. Okay. I'm going to stop sharing, and I left some time for questions if anyone has any topics that we want to dive into a little bit deeper.
I also just want to ask, are folks comfortable with your questions being recorded for future viewers to see, or would you like me to turn off the recording? If anyone wants it turned off, I will turn it off, even with just one vote, and please put that in the chat.
Thanks, Dewey.
Mm-hmm.
I'm also going to just put my email here in the chat. Sometimes asking questions in an awkward Zoom call is not everyone's favorite thing to do. So if you had questions, I'm happy to reply to emails that I get from people that are in this call. How does a parent supplement counter what kids are being taught in school? For example, education for cisgender hetero kids only. Gosh, this has become a hot topic, right? Because different school districts are doing this in very different ways. I think historically, and it's been very clear that sex ed is cisgender heterosexually normative information, and also not very good in general at that. And then so how as the parent do we counter that? I think that there's some really awesome books depending on where you are in terms of age and journey, and one of the most amazing things that I think on the Stand with Trans website is the library. I might have a bias because my mom has been the secretary that organized this library, and she did a really good job of sort of organizing by age and writing reviews, but getting some books to talk about these topics can be really helpful. I think also, if you're able to advocate with your school, then, say, hey, this is tricky, right? Because school board meetings right now, there's angry mobs trying to get rid of all all mention of diversity in terms of sex and gender. But I would say the library on the San Juan Trans website would be a great place to start for educating kids. It's got some really great resources there. Mentioned a couple websites that I didn't write down. What websites did I mention? I'm trying to remember. Do you remember?
I do not remember specific names of the websites, no.
Okay, well, one of the websites that I think is awesome, like that is more medical, that I always tell people to look at if they're interested in like the most up-to-date like medical information, is the UCSF transgender guidelines. I didn't spell guidelines right in the comments, whoops. But that's cool. I don't have the exact website, but if you Google that, that would be easy to find. The version 8 of WPATH has a family acceptance project. Yeah. So that's the family acceptance project is do I have that in?
I think that's San Francisco State University.
Yes, San Francisco State University. But if you type in family acceptance project to Google, they have a whole sort of document that you can print off. There is for schools something really great. If you or you know of someone that's struggling with the school, the Human Rights Campaign has sort of like a guideline for LGBT friendly schools. So Human Rights Campaign HRC school guide. I just put that in the chat, but it's pretty comprehensive to be like, oh, hey, you say you don't know how to do this at your school, here's the guide, and just hand it to the principal and be like, everything you need to know is right there. Yeah, so those are some good ones. And then, have I seen the version 8 of WPATH? What has changed in the child and adolescent sections? So I think the main thing that has changed is that they are no longer really having any guidance on the age that things can be started. They're kind of just saying that you need to have that they do recommend that for adults they are no longer suggesting that everyone needs to see a mental health professional for hormones, but that if a provider is able to review the risks and benefits of hormones for an adult, then using that more informed consent model for adults for hormones could be a valid way to do it. For kids, they're still recommending that mental health assessment in some way is involved, but that assessment can include understanding of risks and benefits of different medications, and not being beholden to age so much as a stage of maturity and making decisions. So I think that's the biggest difference. They're also notably reducing the number of letters that they're suggesting. That used to need 2 different letters from 2 mental health providers for surgery, and they've reduced that to 1. And so I think that's fine and good, but insurance companies oftentimes are the arbiter of this. So insurance companies would then have to say, okay, WPATH 8 says only need 1 letter. Now we're going to change it to 1 letter. Question about parents of trans kids who are terrified of HB 6464 actually becoming law. Is that the one that just came out this morning in Michigan? Is that the number? Yeah. The kid is doing awesome on estrogen, and that going away is not an option. I think this is a tragedy that's on rolling out in different ways in different states. This law has no chance of being signed into law if our current governor is reelected. So she would veto it in Michigan here. You know, am I deluded enough to think that we're always going to have a Democratic governor in Michigan for the rest of time? No, but I would hope that in November we'll reelect our governor, who it seems like we are leaning towards reelecting. If she's not reelected, then my anxiety level is going to go up quite a bit. But I would commit to fight like hell to advocate at the state house for people on both sides of the aisle to understand why that law could have some really significantly negative consequences for the people in our lives that we love. Since we don't have a crystal ball to tell the future, sometimes statistics are useful. Can you share any other stats like the one earlier, 72% of trans men don't end up getting surgery? Yeah, I think so kids that are coming to our clinic, we have the most data on. I would say, we have a skewed sample because kids that are coming to our clinic have maybe strong enough gender dysphoria that it reached the level of attention from a doctor to refer them, and supportive enough parents to bring them to the visit, right? And so the number of patients that are starting on hormones or blockers in some way is actually going down over time, because I think we're seeing more kids that are being referred that are more exploring gender identity and maybe identifying in a non-binary way. And sort of when I talk through like, okay, here's what medicines could do, would that be helpful, or just let your body do its thing and use some non-medical interventions for gender dysphoria? So I would say maybe in the past, maybe more like 75% of people that were seeing our clinic eventually ended up deciding on using a hormonal intervention, whereas now it's maybe down to 65%. I think that the number of people that start hormones and then stop them, I would put it at somewhere around 5 to 7%. The number of patients that I've had that have called me and said, I can't believe that I started them and my gender identity has changed completely. I haven't had that happen to me yet. It has happened to other doctors, and there's people out there that you can see on YouTube that are resentful of the fact that they transitioned. And I hope that says something about maybe our mental health team and our level of assessment. But I'm also not deluded in the fact that someday there might be someone that starts hormones and then decides that was a really bad idea for them. And you know what? That's okay too. I would validate them and say that was the decision you made at the time, but let's see where we go from here and try to help you in a way that makes your life as comfortable and confident as possible. So yeah, Dewey, thank you for sending that link for writing your representatives.
Yeah, absolutely. I feel whoever made that comment, yeah, I feel you. All morning we've been having just a group chat about anything that can be done. But yeah, vote 100%.
Looks like we're getting to the end of the hour. Any other burning thoughts? I also just want to give you all a plug for being such awesome parents to spend your Thursday evening thinking about these things with me. It warms my heart and makes me reminds me that there's a lot of love in this world, regardless of what some crazy people might do in our state houses. So thank you. How long have I been seeing trans kids as patients? Since the start of my fellowship, so 2012, and then I started at U of M in 2015. All right, thanks you guys. Thanks for the nice comments. Should we call it a wrap, Dewey?
Yeah, I think so. Thank you so much for tonight's session, Dr. Schumer.
Of course.
And thank you everyone for joining. Any last questions before we sign off for the night?
I do actually have one last question. Sorry, can I send it in the chat?
Yeah.
Yeah.
Thank you.
Good question. So I think that the biggest thing that I've learned is that regardless of what a parent's opinion is, that it's usually coming from a place of caring, whether it's completely different from what we might think, or slightly different, or maybe not as accepting as as we might think. That it's usually coming from a place of love, but then education about sort of the consequences of rejection from parents, that that LGBTQ kids that feel rejected, whether their parents feel like they're rejecting or not, but when kids feel rejected, their levels of depression, anxiety, suicidality are 5 to 10 times higher than average. That the risk for other seemingly unrelated things like drug use, sexual promiscuity, STIs is much higher than the general population. And so if educating parents that if it's even if having a difference in acceptance based on some sort of political motivation, or a lack of understanding about gender identity, you can motivate parents to become more receptive and accepting based on the idea that that acceptance will help the health of their child. And so maybe it's just starting with, I think the way you feel is the way that many parents feel, and those feelings are valid. But providing this type of education, a lot of that education and information that is found on that Family Acceptance Project website can really move a non-accepting parent closer to acceptance. And sometimes I see a patient with like maybe a resident, and I'm sort of meeting them where they're at and saying, I'm hearing you that that you're not sure about taking any medical steps today. And you know what? Even though our social worker felt like that was a really good next step for your patient, I think that your approach is important because you know your child better than me. So here's some information about the medical options. Let's pick this conversation up back in 6 months. And I turn to that resident and I say, when we come back in 6 months, that parent is going to be ready to talk more seriously about treatment options. And that's what happens. I think meeting parents where they're at and then allowing for that acceptance to come over time. Sometimes time is our biggest ally because we can see a child's gender identity being more and more deeply felt or less and less deeply felt, and that parents can see that over time too. And sometimes time can be the most helpful thing. Cool. Thank you, everybody. Have a good rest of your evening.
Thank you, everyone. And thank you, Dan. I think you just left.